Good evening, everyone. Myself, Dr. Raghu, working as an HOD at Yashoda
Yes.
as Senior Consultant and HOD Emergency Medicine. So every week, Yashoda Hospitals on the Friday, we bring forth interesting, relevant, and up-to-date topics in the field of emergency medicine by expert panelists. So this week, we are with an interesting topic, what's new in the AHA Guidelines 2025. To speak on this topic, I invite Dr. Gopalakrishna, who is my student, the first batch of MD Emergency Medicine at Narayana Medical College Hospital, who is the professor and in charge of the department now. So he'll be talking for the next 45 minutes. So what are the latest guidelines which are updated in the AHA 2025? So over to you, Dr. Gopal.
Thank you very much, sir. It's nice to see you, sir. Is update and give a new set of guidelines, or they will refresh the guidelines so that we can the resuscitation efforts are conducted in a proper way. So the recent changes in the guidelines is with regarding to the guidelines. There used to be a thing called IHCA and OHCA, that is in-hospital cardiac arrest and out-of-hospital cardiac arrest, and there will be a separate links in the chains of survival. For the IHCA, the links are the 6 links are early recognition and prevention of the cardiac arrest, activation of emergency response system, followed by high quality CPR, rapid defibrillation, and post cardiac arrest care and recovery. Whereas in the case of OHCA, that is out of hospital cardiac arrest, the links are activation of the emergency response system, high quality CPR, defibrillation, resuscitation and transport, post cardiac arrest care and recovery. As you can see, sir, in the 2020 chain of survival, there are 6 links. Earlier, there used to be only 5 links in the chain of survival. In 2015 guidelines, there won't be any link called recovery. In 2020 guidelines, they have added a link called recovery to the chain of survival. So, when it comes to the pediatric cardiac arrest, links in the chain of survival as per 2020 guidelines. The same, that is the IHCA and OHCA. To avoid all this confusion, the recent guidelines what they have given is both for adult and pediatric, whether it is out of hospital cardiac arrest or in hospital cardiac arrest, they have given a followed by CPR. So, but now what the AHS is, respirations are rescue equally important. Compressions and also hypo and also rescue breaths. If it is feasible. If it's not feasible, then we can go with just chest compressions only, even for a bystander. Followed by rapid defibrillation and advanced resuscitation, post cardiac arrest care, and recovery and survivorship. So to remove, they have removed all the confusions, whether it's in hospital or out of hospital, whether it is adult cardiac arrest or or pediatric cardiac arrest. They're given a uniform chain of survival for all this population. It's easy to follow also. Coming to the what are the changes I support. Algorithm, there's not much difference between 2020 and 2025 guidelines. The one basic thing they have given is earlier in the 2020 guidelines, they have given a separate algorithm for the opioid-associated life-threatening emergencies. whether the bystander is doing or a healthcare algorithms. So what they have done in the 2025 guidelines is they have incorporated the opioid-associated life-threatening emergencies algorithm into the BLS itself. So as you can see, if you suspect an opioid overdose, we can give opioid antagonist naloxone if available. And what they are saying is even a bystander can give a naloxone and he will not be legally liable. They have given the specifically mentioned regarding the if you suspect an opioid overdose, then you can outright you can give naloxone. They have incorporated the opioid associated cardiac arrest algorithm into the basic life support algorithm. This is the main thing when compared to the adult basic life support algorithm. So the rest of thing is same, sir. The first thing is scene safety, check for responsiveness, we call for help. After calling for help, you check for the patient is having a cardiac pulse, if the patient is having any spontaneous respiratory efforts, breathing or only gasping. No pulse, no breathing, you immediately start the CPR beginning with chest compressions. So nothing much changes from the 2020 and 2025 guidelines, apart from they have incorporated the opioid-associated cardiac arrest algorithm into the BLS algorithm itself. The AED placement paddles. This has been changed. Lateral placement of the AED pads. So one pad is placed on the right side of the chest, immediately below the right clavicular region, and another pad is placed below the left armpit, just a few inches below the left armpit. Pads are being placed. So what they have specifically mentioned is we can also place the pads in the anteroposterior pad placement. Even in adults, one pad can be placed over the sternal region and other pad can be placed in between the two scapular blades on the back of the chest. And one more paddle placement, as you can see, one pad can be placed to the left side of the chest and another pad can be placed below the left scapula. This pads has been changed, modified, and compared to the 2020 guideline. Help start the CPR, push hard, push fast. Use the AED as soon as the AED is available because each minute counts and each minute lapse in the defibrillation results in 7 to 10% less chance of survival of a cardiac arrest victim. So if you suspect opioid overdose, give naloxone. Don't hesitate to give naloxone. So one more thing is foreign body in the airway obstruction. So the first thing we should do is scene safety. Earlier there won't be any algorithm for choking. In the 2025 guidelines, they have given a specific algorithm and what to do if you encounter an adult victim with choking, what to do if you encounter a child with choking or infant with choking. So whenever you see an adult victim with a foreign body in the airway or foreign body obstruction, the first thing we should do is verify scene safety, see whether the scene is safe or not. Then we check for the signs of the severe foreign body airway obstruction. So the signs like any weak or absent cough, unable to speak, or any cyanosis, altered mental station apnea. So if there are no signs of any severe foreign body airway obstruction, then you should encourage the patient to cough out the foreign body. So if the signs of any severe airway obstruction are present, then immediately you should activate the emergency response system. Victim is responsive. We should give 5 back blows and 5 abdominal thrusts. We should repeat the maneuvers until the foreign body is expelled out. Earlier, 2020 guidelines, they have mentioned only abdominal thrusts only. They have mentioned regarding Heimlich maneuver only. They have not mentioned regarding the back blows. But the 2025 guidelines, what they specifically say is, you first start with the 5 back blows, followed by 5 abdominal thrusts, till the foreign body is expelled out. The rest all remains the same. The victim becomes unresponsive, we should start the CPR, and each time while giving the rescue breath, we should easily removable foreign body foreign body, otherwise we should not attempt a blind finger sweep technique. Okay, rest of the algorithm is same. Apart from that, the 5 back blows has been incorporated into the adult foreign body airway obstruction algorithm. First, if you so so operation pressure released, and as a result of that, the foreign body will be pushed out or expelled out. So first give by 5 back blows followed by 5 abdominal thrusts. The same thing, we are encountering a victim as a child. So even if we encounter a pediatric or child victim, the first thing we should do is 5 back slaps and 5 abdominal thrusts. So when coming to the pediatric change by the PDD guidelines, the scene safety check for responsiveness. If the patient is having any abdominal breathing, we should, if the pulse is present, we should open the no pulse, no small thing difference is when you are a single rescuer or when you are experiencing a scenario with 2 or more rescuers. If you are a single rescuer, the first thing we should do is when to do CPR first or when to do CPR phone first or phone fast. So if it is a witnessed cardiac arrest, what we should do is we should go activate the emergency response system and come to the victim and perform the CPR. If it is an unwitnessed cardiac arrest, what we should do is we should perform 2 minutes of CPR or 5 cycles of CPR. Then we should go and activate the emergency response system. These are much more similar to the 2020 guidelines only. No much difference when compared to the 2020 guidelines. As you can see, the heart rate is less than 60, signs of poor perfusion. We should definitely go with the CPR. And also, if you suspect a opioid overdose in the case of a pediatric cardiac arrest or pediatric infant cardiac arrest, immediately we should start giving naloxone. Naloxone. Infants or child with cardiac arrest. So if there are 2 or more rescuers, so the steps are very much the same. Scene safety, check for responsiveness, activate emergency response system, check for the pulse and breathing. No pulse, no breathing, start the CPR immediately. These guidelines are very much similar when compared to the 2020 guidelines. No difference between the pediatric basic life support guidelines with 2 or more rescuers. So CPR technique, this changes. So CPR technique, when we call a victim as a children, we call a victim as infantis. If the victim is less than 1 year, we call victim as an infant. If it's 1 year to the onset of puberty, we call the victim as a child. After the onset of puberty, we consider the victim as an adult. So in of a child with cardiac arrest, 2-hand technique for chest compressions is preferable. We are not able to. So by doing the CPR, we should be cautious that the depth should be adequate. In the case of a child, it should be approximately 5 centimeters. When coming to the infant CPR, earlier what they have said is, if you are a single rescuer, do a 2-finger technique of delivering the chest compressions. If you have 2 or more rescuer, you should do a thumb and circling technique of delivering the chest compressions. You should compress a depth of at least 4 centimeters. But the new guidelines, what they say is, they have removed the 2-finger technique of delivering the chest compressions. What they felt is, 2-finger technique cannot adequately deliver the chest compressions. So what they are saying is, to a single rescuer, you can compress the center of the chest with a single hand. Make sure that the depth is at least 4 centimeters. If you are 2 or more distress, two-thumb encircling hands technique is preferable. If you're not able to deliver the technique compression adequately with the two-thumb encircling technique, then you can deliver the chest compressions with single hand technique. So this is a slight modification. They have given the technique of delivering the chest compressions in the case of the infant we check for responsiveness, see whether the patient is infant is crying or any coughing. So if the minimal signs of airway obstruction, we encourage the infant to encourage cough and continue to check for signs of severe foreign body airway. So if there is a severe foreign body airway obstruction, then we should give 5 back blows followed by 5 chest thrusts. As you can see, we should give 5 back blows in between the 2 sample blades and 5 chest thrusts. Earlier, we used to give chest thrusts with the 2-finger technique. We can give the chest thrusts with the single hand technique, in the case of an infant. This is a slight modification of the chest thrust technique when compared to 2020 guidelines. So there is a difference between foreign body airway in the adult, child, and infant. Adult, 5 back slaps and 5 abdominal thrusts. Children, 5 back slaps and 5 back slaps and 5 chest thrusts. So if the infant becomes unconscious, immediately we should start doing the CPR. So this is a child foreign body airway obstruction algorithm. 5 back blows and 5 abdominal thrusts. As you can see, this is a child with foreign body in the airway. So first give 5 back blows and 5 abdominal thrusts. By kneeling behind the victim, we can give 5 abdominal thrusts. So when coming to the adult cardiac arrest algorithm, nothing much has changed. So we'll see a patient with the cardiac arrest, start the CPR and continue the CPR. While doing the CPR, we give epinephrine for every 3 to 5 minutes. With the shock rhythm, we go with DC shock to 200 to 120 to 200 joules. If it's a biphasic defibrillator. If it's a monophasic defibrillator, we give 360 joules of DC shock. And high quality CPR characteristics also, nothing much has been changed. So what they have emphasized is we should always while doing a high quality CPR, always monitor the ETCO2. If the ETCO2 is less than 10 millimeter of mercury, we should try to improve the CPR quality. And one more thing they have mentioned is if the ETCO2 is low or even if it is decreasing, we should reassess the quality of the CPR. And one more thing is while using the LMS or any extracorporeal devices, we can't reliably measure the ETCO2 values. Rest of the thing, nothing much has been changed. You should always remember the 5 H's and T's while resuscitating adult cardiac arrest victim. So we should always look at the H's and T's. This is the adult cardiac arrest algorithm. Hello?
Okay.
Hello?
Hello?
Sir, one more thing, sir.
Go ahead.
Okay, sir. Right. Nothing much has been changed when compared to the adult cardiac arrest algorithm. Always epinephrine is the drug of choice. So every 3 to 5 minutes in the case of a cardiac arrest with the presenting rhythm of asystole, shock the patient immediately. And after 2 shocks, then we can consider giving epinephrine. If the VF or VT is refractory even to 3rd shock, then we should consider giving amiodarone or lignocaine as an antiarrhythmic agent. Coming to the to terminate the resuscitation rules. When compared to the BLS, when to universal termination of resuscitation rules, they are given 3 conditions. If the arrest is not witnessed by the whenever the emergency medical services reaches the scene, if the arrest is not witnessed by the emergency medical services personnel, if there is no return of spontaneous circulation before the transport, if there is no AED shock was delivered before the transport, if all the 3 criteria are met, then we can consider termination of the resuscitation effort. If any one of the criteria is present, then we should continue the resuscitation effort and consider transport the patient to a nearest medical facility. Coming to the advanced life support, when to consider termination of resuscitation is the arrest is not witnessed, when there is no bystander CPR, there is no return of spontaneous circulation before transport, no shock was delivered before transport. If all the criteria are present, then we should consider termination of resuscitation. If any one of the criteria is present, then we should continue the resuscitation and consider transport to a nearest medical facility. So many changes have been given to changed when coming to the adult tachyarrhythmia, the pulse algorithm. So what they have specifically mentioned is patient usually will be symptomatic. The heart rate is more than or equal to 150 beats per minute. And what they have specifically said is if the heart rate is less than 150, no point in giving the synchronized cardioversion. So whenever we see a patient tachyarrhythmia, always start with the ABCs and see whether the arrhythmia is stable or unstable, or whether the arrhythmia is symptomatic or asymptomatic. So if the patient is unstable, you should go for a synchronized cardioversion. If the arrhythmia is asymptomatic or the patient is stable, then you can go with chemical cardioversion. So what I have specifically mentioned is coming to the antiarrhythmic infusions. For stable white QRS tachycardia, earlier there used to be procainamide, amiodarone, and sotalol. In the 2025 guidelines, sotalol has been removed from the antiarrhythmic infusions algorithm. They have given only procainamide and amiodarone as the antiarrhythmic agents, drugs of choice. And one more thing is, when coming to the synchronized cardioversion, what I specifically mentioned is, when in the 2020 guidelines, what I said is, we should deliver in the 2025 specific as you can see, when we see a patient with tachyarrhythmia with serious signs and symptoms caused by the tachyarrhythmia, so it's unstable tachyarrhythmia, we should always go for a immediate synchronized cardioversion. The 150 beats per minute. Always keep specific energy doses for synchronized cardioversion. As you can see, the case of atrial fibrillation or atrial flutter, they are given a dose of 200 joules. Narrow complex tachycardia, they have removed the name of supraventricular tachycardia. So they have given just a narrow complex tachycardia. That is, it needs an energy dose of 100 joules. In the case of monomorphic beating, it needs an energy of 100 joules. So whenever we see a polymorphic beating, unsynchronized high agent, they specifically mentioned drugs like diazepam and fentanyl. So 20 guidelines are specific how much has to level of tachyarrhythmias. The bradycardia, so the bradycardia is symptomatic, bradycardia is symptomatic, then we should initially try with the atropine doses. The atropine is not improved with atropine, then we should go for dopamine or epinephrine infusions or transcutaneous spacing. If it's not improved even with transcutaneous spacing or dopamine and epinephrine infusions, then you should always go for expert consultations and transvenous spacing. So the one thing they have mentioned in 2025 algorithm is how to approach a patient with adult or pediatric patient with left ventricular assist device algorithm. So how to approach is we see unresponsive adults or children with a durable left ventricular assist perfusion. The so how to we should look at the skin color, temperature, capillary density. We have a arterial line, you should monitor the arterial line. You look for the ETCO2 values. So as is the perfusion. The patient is adequately perfused, then we should monitor the patient and transport the patient to a facility and contact the ventricular assist device center. You to the monitor the perfusion. The patient is not adequately perfused, then you should any equipment failure, any hemorrhage, hypovolemia, hypoglycemia, hypoxia. So look for this. Look for the non-left ventricular assist device called unresponsiveness. So you should always for the any other causes which causes the patient land into unresponsiveness. So coming to the pediatric cardiac algorithm, nothing much has been changed. So it's much similar to the 2020 guidelines only. So single risk care, you go with the 15:2, 30:2 chest compressions. If more than 2 risk care, you go with the 15:2 chest compressions. So nothing much has been changed. Doses are also much more similar only. Nothing has been changed. The Pediatric pulse algorithm is also much similar only. Apart from that, we give only 2 doses of atropine. Each dose is 0.02 mg per kg. Only 2 doses can be given. Minimum dose is 0.1 mg and maximum dose is 0.5 mg. Apart from this, the rest of all is similar to the 2020 guidelines only. Support ABCs and see whether the bradycardia is symptomatic or non-symptomatic. Some pediatric is also much similar as a wide complex or narrow complex. In the case of adults, if the QRS duration is more than 120 milliseconds, we call it as a wide complex. If it is less than 120 milliseconds, we call it as narrow complex. In the case of a pediatric tachyarrhythmia, if it is more than 90 seconds, we call it as a wide complex. Less than 90 seconds, we call it as a narrow complex. So nothing much has changed when compared to the 2020 guidelines. Especially cardiac arrest and pregnancy algorithm. So there has been a slight changes when compared to 2020 guidelines. Earlier we used to call a condition called perimortem cesarean section. So whenever we encounter a pregnant lady in cardiac arrest, what we used to see is we should resuscitate the victim. While doing a CPR, we should displace the uterus to the left side of the patient or place a wedge over the right, beneath the right hip of the patient. Continue the CPR and we should look for to deliver the baby within 5 minutes. So everything is same only, but apart from that, they have removed the term perimortem cesarean section. They have given a term called resuscitative delivery. So one more experienced provider or who is a airway expert or who is experienced in securing the airway immediately, should go with the airway management, and also place IV above the diaphragm. And if the patient is receiving IV medication and the patient has collapsed, we should stop giving magnesium sulfate and we should give calcium gluconate or calcium chloride. And also one more thing is, with the patient, if you suspect a amniotic fluid embolism as a cause of the cardiac arrest, then we should immediately activate the massive transfusion protocol. Because whenever there is a amniotic fluid embolism, the amniotic fluid contains a tissue factor, which is a procoagulant. It when coming to the systemic circulation of the mother, it causes a consumptive coagulopathy. So there will be consumption of the clotting factors and patient will bleed massively. So whenever you suspect amniotic fluid embolism, always go to the massive transfusion protocol. Just we go for give PRBCs, FFPs, and platelets in a 1:1:1 ratio. And one more thing is, the specifically mentioned who all should be present when resuscitating a cardiac arrest in pregnancy. So there should be a team leader, there should be a high performance team, anesthesiologist, obstetrician, neonatologist, nurses, pharmacists, and other persons to resuscitate the cardiac arrest victim, cardiac arrest pregnant lady or pregnant victim in cardiac arrest. So the baby should ideally be delivered within 5 minutes, depending on the local sources. Difficult area has to be managed by the experienced professional. So we should always look for the etiologies of the cardiac arrest. So as you know already, anesthetic complications, bleeding, cardiovascular complications, any drug toxicities, amniotic fluid embolism or pulmonary embolism, fevers, general causes as in HSNTs, and hypertension, that is eclampsia and preeclampsia. So the post cardiac arrest, okay. Yes. So after so and made a 90 to 90 to 90. It corresponds to specifically given a target map. Target map should be maintained greater than or equal to 65 millimeter of mercury. Earlier, what they have said is they have given systolic blood pressure. Systolic blood pressure should be maintained more than 90. MAP should be maintained more than or equal to 65 millimeter of mercury. They remove the term systolic blood pressure. They just given the term MAP. Mean arterial pressure has to be maintained more than or equal to 65 millimeter of mercury. And one more thing is the continued so should go for a targeted temperature management. And one more thing is, what's the temperature? What is the temperature for a targeted temperature management? So what they have mentioned is, earlier they used to say 32 to 34 degrees for at least 24 hours. The current guide is for 36 hours. They are given a specific mentioning. And also, we should evaluate for seizures. So we should go for a continuous EEG monitoring also. And also, multimodal approach with the neuroprognostication should be done only after 72 hours from ROSC or from attainment of normothermia. And one more thing is, we should avoid hypoglycemia. That is, glucose should be maintained more than 70. We should avoid hyperglycemia, that is, should be maintained less than 180. And we should target a MAP more than or equal to 65. And we should consider giving early antibiotics. This has been changed when compared to the previous guidance. Consider giving early antibiotics. So these are all the changes on this guidance. So 2020 guidance, what they say is they have added a sixth link in the as a recovery to the chain of survival. Earlier there used to be only 2015 guidelines. There used to be only 5 links. 2020 they had this sixth link, that is recovery, and they have given a separate the chain of survival for IHCA, OHCA, pediatric and adults. So to remove all the confusion, 2025 they have created a single chain of survival for both IHCA, OHCA, adult and pediatric chain of survival, so that proper prevention and preparedness can both avoid the need for and optimize the resuscitation. And coming to the infant chest compressions, so the two-finger technique has been removed when compared to the we can when if you are singular technique, earlier there used to be a two-finger technique. It has been removed. And also, if the rescuer cannot physically encircle the infant's chest, compress the chest wall with the heel of the one hand technique is preferred. And also, they have incorporated the opioid-associated emergencies, opioid-associated life-threatening emergencies into the BLS algorithm itself. No separate algorithm for opioid-associated emergencies now. Coming to the foreign body of the airway. So, as you can see, in the case of adults, children, and infants, adults, 5 back slaps. Earlier, it used to be only abdominal thrusts only. But now they have given 5 back slaps and 5 abdominal thrusts in the case of an adult for foreign body airway expulsion. In the case of children, 5 and 5 abdominal thrusts. And also the method of giving the chest thrust is the heel of the one hand technique of delivering the chest thrust. So the opioid-associated emergencies or opioid antagonist naloxone has been incorporated into the pediatric and adult basic life support algorithm itself. Coming to the ACLS summary, when coming to the tachyarrhythmia algorithm, the specifically mentioned guidelines to how much energy we have to select for the synchronized cardioversion. Narrow complex tachycardia, they have removed the term SVT. So narrow complex tachycardia, the dose of energy selection is 100 joules. For the monomorphic VT, which is 100 joules. CT has to be algorithm, and also they have changed the name of supraventricular tachycardia into narrow complex tachycardia. When coming to the post cardiac arrest care, the earlier the targeted temperature management is 32 to 36 degrees centigrade for at least 24 hours. Now it has been changed to 32 to 37.5 degrees centigrade for 36 hours. And do not give OHCA patients in the earlier, what they're saying is 2020 guidelines. Do not give OHCA patients with ROSC, targeted temperature management, but in 2025 guidelines, even if it's out of hospital cardiac arrest patient with ROSC, temperature control as long as not temperature, that TTM can be given, even if it isn't cardiac arrest. The oxygen saturation, the targeted SpO2 values has been changed. 2020 it's 92 to 98 degrees centigrade. Now it has been changed to 90 to 98, 90 to 98%. And a single link in the universal chain of survival. And one more thing is when coming to the stroke algorithm. So what I have said is, according to the US FDA guidelines, the only thrombolytic agent is RT+. 2020 guidelines, they are used to give only RT+ as a thrombolytic agent. If at all the patient presents in the window period of 12 hours, the dose is 0.9 mg per kg body weight. Now what they are saying is they have added tenecteplase also as a thrombolytic agent for acute ischemic stroke. So the tenecteplase is very easy to administer. The dose is 0.12 mg per kg body weight, can be given as a rapid IV bolus, and it is easy to administer and easy to monitor also, monitor the patient, monitor for the blood pressure also. So they incorporate the tenecteplase as thrombolytic agent in 2025 guidelines. When coming to the ACS, there is the acute coronary syndrome. The earlier what they used to say is they used to consider left bundle branch block as a STEMI equivalent. So now what in the 2025 guidelines, what they have decided is remove the LVAD as a definitive diagnosis of STEMI. And also they have removed the clopidogrel as a primary anticoagulant. And also as an alternative to morphine for pain control, they have added fentanyl also. Fentanyl also can be given for a pain control. And also for anticoagulation, we can give enoxaparin or fondaparinux. Earlier they used to mention only heparin, sunfraction heparin only. Now we can also use enoxaparin or fondaparinux as an anticoagulant. And also what they have mentioned is try to add AC inhibitors, because AC inhibitors limit the infarction size, limit the ventricular remodeling. So try to give AC inhibitors if you encounter a patient with acute coronary syndrome. And also when coming to the airway, what I mentioned is earlier they used to say 600 to 800 ml of ventilations for each breath. So what now they are substantiating, or what they are addressing is just give 1/3 to 1/2 bag squeeze, sufficient enough to cause a chest rise. See for the chest rise. Don't try to look at the tidal volumes. Look for the chest rise. So while giving the ventilations with the ambo bag, just give a half bag squeeze, 1/3 to half bag squeeze, so that the chest rise is visible, because a visible chest rise. And also always use a ETCO2 to monitor the CPR quality, or always use ETCO2 to monitor whether the patient is whether the airway is patent, or the ET tube is in position or not. And also they have earlier what they say is some of the drugs can be given by endotracheal route also. So when we are practicing our postgraduate program, we used to give lignocaine, adrenaline, atropine, and naloxone can be given by, what we studied is these four drugs. That is lignocaine, epinephrine, atropine, and naloxone can be given by endotracheal route also. But now what they're saying is they have removed the delivering medications down the endotracheal tube. And one more thing they are emphasizing is, so while securing IV access, if at all IV access is not possible, then you can go for IO access. Earlier, what they used to say is IO or IV access is preferable. Now they're emphasizing more on the to go for a IV access. If IV access is not feasible, then only you should go for a IO access. And one more thing I want to stress is never go for a central line placement in case of any resuscitation of victim, because short whiteboard canvas can resuscitate the victim very fast. So these are all the basic things which I want to emphasize, and these are the small changes when compared to the 2020 guidelines. So always be prepared to save lives, and thank you. If at all any questions are there, I feel comfortable to ask them. Thank you, sir.
Thank you, Gopal, for that elaborative talk. So, as we all know that every 5 years, the AHA along with the ILCOR, they come with the updated guidelines after many research things. So, Dr. Gopal has briefly elaborated what are the new guidelines which were there from 2020 to 2025. So, if you have any questions, so Dr. Gopal will be ready to take it on. If there are no questions, we'll close the session. So I thank Yashoda Hospital in association with SEMI and NBI. So every week, every fortnight, so they come up with a interesting latest update with the expert panelists in the field of emergency medicine across the country in their expertise in the emergency medicine. So I thank Yashoda Hospital once again, and I thank Dr. Gopal for taking his time and giving a brief session on the latest updates. Thank you, Gopal.
Sir, thank you very much, sir. Thank you, sir.
Yeah.